Yes, good morning. So I'm going to present the second part of my year in review 2021. Yesterday we spoke about stroke and traumatic brain injury. While today I'm going to speak on delirium, ICP, neuro monitoring, encephalopathy, sedation, and analgesia. Now, when we talk about the delirium is still one of the burning issue in most of the critical care unit. It is generally the clinical manifestation of the brain dysfunction in critical care unit, and most of the intensivists are still facing the major challenge to diagnose the delirium, to prevent the delirium, and treat the delirium. So, when we are talking about the delirium, we are generally interested in diagnosing the delirium, what type of the phenotype, and how we can prevent those delirium, because it is directly related with your length of ICU stay, length of hospital stay, mortality, number of ventilated days, and so many things related with the delirium and how to treat that. So I came across, this was one of the recent systemic review regarding the pharmacological and non-pharmacological interventions to prevent the delirium in critical care patient, that is close to the all intensivists, and it was published in intensive care medicine journal. So when this was a quite robust way, they have selected the most of the studies related to the delirium, and then finally they have landed with the a few one where they can discuss the what is the impact of the delirium in critical care unit and how to diagnose, prevent, and treatment. Now when we talk about the delirium, generally there are the certain drugs to we have in our armamentarium, whether it is pharmacological as well as the certain non-pharmacological this thing. So sorry for this particular slide quality, that's why I have written here. So these are the drugs like alpha 2 agonist, sedation interruption, protocolized sedation, opioid plus benzodiazepine, antipsychotic, melanoin, propofol, opioid alone, opioid short acting alone, and benzodiazepine. So this is a list of the drugs and the non-pharmacological intervention which we may use to prevent this thing, and what is its impact on various parts of the delirium, like delirium's incidence, duration of mechanical ventilation, length of ICU stay, length of hospital stay, mortality, and arrhythmias. And if you see one by one, and this was one of the best review I came across to give the overall idea about how we face the delirium in an ICU. So if you see the alpha 2 agonist, then sedation interruption, protocolized management, opioid benzodiazepine, they may help. If you see the statistically significant, the only opioid alpha 2 agonists are in favor of preventing delirium as compared to the benzodiazepam and as compared to the propofol and other drugs. But your sedation interruption or protocolized sedation may help or add into the your management in prevention of the delirium. So on this side, there are where the odd ratio is less than 1 is generally in favor of the prevention of the delirium oxygen. When we talk about the duration of mechanical ventilation and the shorter duration mechanical ventilation, again your alpha 2 agonists do the good job. Then might be your propofol and your antipsychotic does not, but propofol and these drugs may help you. But again, the alpha 2 agonist is the drug which stands there to prevent or reduce the duration of the mechanical ventilation in a delirium patient. Length of ICU stay, again your alpha 2 agonist again is one of the main concern. Interruption, analgesics, or protocolized sedation may help to reduce the length of ICU stay, and length of hospital stay again the same. So if you see in prevention of the delirium as well as the reducing the length of ICU stay and hospital stay, alpha 2 agonist is one of the most proven and accepted drug, that is the dexamethasone, in delirium management in ICU. And along with sedation interruption, protocolized sedation may help you against the antipsychotic and the propofol and this thing. That's what we have came across through this review. And this was wonderfully seen from left to right. Is the top is the alpha 2 agonist should be the first drug of choice, then sedation interruption, then protocolized sedation, and then you can try opioid benzodiazepine as per the situation. as compared to the placebo. So when you compare with the placebo, your dexamethasone is one of the drug of choice for prevention and management of delirium in ICU. So what this particular review gives us an idea that there are so many effective interventions we need to do to treat the delirium and reducing the high incidence of delirium in ICU. But one of the important take-home messages is that compared to the placebo or benzodiazepam, dexmedetomidine is probably one of the choice of the drug for prevention of the delirium. That's what we concluded out of this wonderfully done the systemic review. And sedation minimizing, that means you can withhold or interrupt the sedation strategy that targets may reduce the sedative related delirium, and antipsychotic drugs may not prevent the delirium. So you need to titrate your drugs, the selection of the drug, the dose of the drug, the selection of the patient, and the duration of the that particular sedatives, which may help us to prevent the delirium. Now regarding the ICP, when we talk about the ICP, now all of us are well versed with that 2012 Latin American trial, best tip trial, which shows that your clinical and your clinical management compared to the ICP was not very much difference. But then there are so many other evidences now available which is in favor of the ICP in certain group of the patients, like a moderate to severe. So what is the crux of this topic is ICP monitoring. Yes, it is one of the intervention which reduces to intracranial pressure is acceptable in the neuro ICU, provided that your ICU should be well geared up. There should be the adherence to the protocol, adherence to the ICP monitoring. Those units do well with the ICP monitoring as compared to the intermittent or once in blue ICP monitoring. So this was another international prospective observational course study I came across, which is the Synapse ICU, where the intracranial monitoring was done in acute brain injury. What they did, it is not the only traumatic brain injury. They selected the acute brain injury patients, like one cohort was a traumatic brain injury, second cohort was a SH, and the third cohort was a stroke patient. So in these patients, IC bleeds, they have done the ICP monitoring and the ICP management. And they have just gone through the detail. When I have gone through these details, they have ICP monitor almost out of the 2000 plus patient, 1000 were ICP monitoring and 1000 were not ICP monitoring. And the cohort of the traumatic brain injury, subarachnoid hemorrhage, and IC bleed. And if you see the age group, generally the younger patients may get benefit of the ICP monitoring. High income countries, because it's a costly affair, it may get in favor of the ICP monitoring. Then if the patient has a comorbidities like a diabetes or cardiovascular disease, they may get the help of the ICP monitoring. Now they one of the interesting things, they have seen the pupillary reactivity. Those who are bilateral pupil reactive, one pupil reactive and one pupil unreactive, and bilateral unreactive patients group of this thing. And they found that there is a difference in outcome in terms of the pupillary unreactivity, whether it is a single pupil unreactive or both pupils unreactive. And the severity of the illness, generally the moderate to severe disease like 3 to 5 and 6 to 8 GCS, it is definitely the helping the ICP monitoring. And those were documented CT and MRI contusions, moderate to severe, may help with the ICP monitoring. And during the study, they have found that one of the commonest site of doing the ICP insertion is your ICU, and the neurosurgeon was the person who was doing the majority of the ICP monitoring. One of the most common method of doing was the parenchymal as compared to the intraventricular, and then the antibiotic prophylaxis, and then ICP monitor in up to the 3 to 5 days. This is how they have gone into the detail of the ICP monitoring. And what they found at the end of the again, it is a clinical outcome related study. At the end of the 6 months mortality, they came across that moderate to severe group of the patient, it may help in getting some results or reducing the 6 months mortality. And the patients, those who are at least one pupil unreactive, they may get the help. Like so, at least one unreactive pupil, you may get the odds ratio less than 1, and this is what they have came across with the all three subgroup, like a TBI as well as the SH and the IC bleed, where the at least one reactive pupil may get benefit of doing the ICP monitoring. So to summarize this prospective international study regarding the ICP, patient in whom ICP monitoring might be associated with the improved 6 months outcome is there is certain type of the phenotypes of the patients, like a moderate to severe group of the acute burn injury, they may get help. And those who are the age and comorbidities and those who are the cities finding are generally you can use the ICP monitoring in this particular type of the patients. And monitoring of the ICP is associated with the more aggressive therapeutic approach and the higher in ICUs, and might have protective effect on the 6 months mortality. So it was a positive, but again, you need to select your patient, you need to see the clinical condition, and then that particular group of the patient, and your unit has to be the geared with the ICP monitoring rather than intermittent or infrequent ICP use. Now, third part is neuro monitoring. We talk a lot about the neuro monitoring, invasive neuro monitoring, non-invasive neuro monitoring. This was one of the quick review I came across in a critical care, very interesting. And generally, we would like to know the hypoxic ischemic brain injuries. Which one is better to for whether non-invasive or invasive to picking up and offering the oxygenation to the brain. We know the clinical examination is still gold standard, followed by your rest of the this thing. But when we talk about the invasive versus non-invasive, the near infrared spectroscopy is a non-invasive way of doing the neuro monitoring as compared to the oxygen measurement from the brain, invasive oxygenation from the measurement. So both are attractive, both are reliable. But if you see the head-to-head comparison, the invasive, the one of the major advantage of the invasive is that it gives you the local oxygen changes. So rather than giving the generalized oxygen status of the brain, it gives you the quicker and the local oxygen and the brain changes, and that is more reliable as compared to the non-invasive. But again, it is costly, it requires the expectation, bleeding complications, and not many studies are available, are not in favor of the invasive. On the other hand, the near infrared spectroscopy is a non-invasive, hardly any complications because it's easy to initiate, fast to initiate, but it offers the global oxygen assessment. Invasive always gives you the local oxygen changes, while this offers the global oxygenation. That is only the thing which may be weaker as compared to the invasive, but the lower cost is in favor of that. So quicker, faster initiation, lower cost, availability, and global oxygen, this thing are in favor of the non-invasive. So you need to select whichever, whether it is invasive or non-invasive in acute brain injury. If you would like to go ahead with the status of the hypoxic brain damage, and generally this is very common of the post cardiac arrest, you need to do the neuro monitoring. So it underlines the importance of the your neuro monitoring. Whether you go for non-invasive or invasive, you need to judge which one is the most suitable, available, and give you the age over the management of that particular patient in post cardiac arrest situation or acutely this thing. And then as already I explained, the non-invasive, they are generally the easily available, not very costly, faster this thing. They give the real-time signal, but again they give about the global oxygenation status, while your invasive catheters gives you the local brain flow and oxygen, which are more reliable and quicker. You can this thing, but again it needs the cost and the skill and your bleeding complication and rest of the things are not easily available across the many centers in India. So you need to select your, but this was a good article which compares the non-invasive versus invasive to know what is your cerebral oxygenation status in that particular patient and helps in management. Now, fourth part is the encephalopathy. All of us know that acute liver failure can lead to the cerebral edema. And if you see the grades, grade 1, 2, 3, 4, generally we are concerned with the grade 3 and 4. So which are the drug of choice? We all of us very regularly using the mannitol. Now we started using the hypertonic saline, and in traumatic brain injury now it is quite established concept of the using the hypertonic saline. This was the Indian study. I like this Indian study, which was a prospective single center study, which compared the head-to-head mannitol versus hypertonic saline. The number is not very large, but in hepatic encephalopathy, grade 2 to 3, which is known as a Mahal study, I think this number gives you the overall idea about the which one might be safer and useful in using the cerebral edema in acute liver failure. And when they compare the 60 patients, in both groups, they were having the 25 patients, and the end point was reduction in the ICP. So primary objective was reduction in ICP at 12 hours. Secondary objectives were reduction in ICP at the 6 to 24 hours. And to find out the rebound cerebral edema, which is the known phenomena in acute liver failure, and any other complications related with the drugs. This is what the overall structure of this study. And when they gone through that, there is no major difference in terms of the mortality in both groups, whether it is a 3% hypertonic saline or mannitol. There was no difference in the mortality in acute liver cell failure and grade 3 to 4 edema. But what they found, the INR, arterial ammonia, serum lactate, they are the predictors of mortality. So serum lactate more than 3 is almost 70 to 72% sensitive and specific. Arterial ammonia is 66 to 60% sensitive and specific. And INR more than 4 is 66 to 60% sensitive and specific in predicting the mortality. And when they conclude with the primary and secondary objective, they have found that hypertonic saline and mannitol shows equal efficacy in reducing the ICP at the 12 hours in a year. So if you compare the both agents, they are equally effective. But the most important observation of this study was mannitol is associated with the more episodes of acute kidney injury and rebound cerebral edema. So definitely the hypertonic saline has some edge over the mannitol in terms of less rebound cerebral edema incidences, as well as less episodes of the AKI. Around about 3 to 5 episodes of cerebral edema, rebound cerebral edema happen in mannitol group and 0 in hypertonic saline. So yes, we can use hypertonic saline in a management of the cerebral edema in acute liver failure. So 3% hypertonic saline could be recommended for the ICP management in ALF. Now, when they how they followed, when they selected the patient, enrolled the patient, and which fulfills the criteria, they followed the raised ICP on the basis of the optic nerve sheath diameter and the pupillary index, middle cerebral artery pupillary index. Optic nerve sheath diameter more than 5, so a cutoff was a 5. So when you give the mannitol or hypertonic saline, if their values are less than 5 or your pupillary index is less than 1.2, that. So these are the good, effective, useful bedside tool for the diagnosis of the cerebral edema. Now, no need to go for the imaging like a CT, MRI and diagnose. So nowadays we do the optic nerve sheath diameter on a regular basis at the bedside as a tool for diagnosing, non-invasive tool for diagnosis of the ICP. And it is very reliable. Now, the last part of the my talk is again, this is a viewpoint. Let me tell you, I selected this viewpoint because so it was clearing our doubts about the certain drugs. They are so much day-to-day practice. We need them, like a ketamine. Initially, a few years back, ketamine was contraindicated in a raised ICP management because they thought to be increasing the ICP. But I think now that concept is almost, there is a good evidence is available that ketamine is one of the most preferable, potent, reliable sedative analgesic, which in various situation you can use in a brain injury. So we always say that the ketamine is an old drug for the new users, but I will say that somehow we misinterpreted or misunderstood these drugs, and that was not in practice for managing the raised ICP in acute brain injury, but now it is come back with the quite good indication. And this article summarizes very well where the various situations where you can use ketamine in a various situation of the traumatic brain injury, like pre-hospital setting. If the patient is in a transport in an ambulance, or patient is in a casualty, whether it helps to stable the hemodynamic profile, avoiding the hypotension, reducing the use of the fluids, maintaining the spontaneous ventilation. So it is a potent analgesic, it is a good sedative, but it doesn't causes the hypotension, it doesn't causes any arrhythmia. It is in fact the neuroprotective, it doesn't causes the raise ICP. This is a good drug to for the even rapid sequence intubation. So pre-hospital setting, yes, you should use the ketamine on priority. If suppose the patient has in a hypotension or in a shock, a drug you need to use for the good sedation or for rapid sequence hemodynamic instability, you can use the ketamine. Airway resistance is increased, like in TBI with asthma and COPD, the ketamine will give, because ketamine itself is a we can use as a bronchodilator. So this may give the age or reducing the airway resistance in asthma and COPD in cases of the traumatic brain injury, and you can go ahead with the advantage of that. Then refractory convergence in ketamine drip, ketamine in infusion is one of the choice for refractory status epilepticus, and we can use that drug because it doesn't causes the hypotension and it controls the seizures. When there is a need for the non-opioid analgesia, yes, ketamine will be the drug of choice. Conscious sedation, you don't want to be a deeply sedated patient, you want to do the some neuro assessment, or you would like to have a weaning process, you can use the conscious sedation with the ketamine. Yeah, GI dysfunction is there, yes, you may use the ketamine, or withdrawal syndrome. So though this is an old drug, though this is a somehow was neglected in past, now it come back with the so many advantage and so many indications in a traumatic brain injury. So I will strongly prefer that the ketamine should be the one of the drug in your armamentarium where you can use it in a selective cases and get the advantage of this drug. And that is what we have learned in last 1 year about the various situations in acute brain injury as well as in traumatic brain injury. Thank you.